obviously, the cancer care review will automatically come up on your EMIS screens. You've got the first one, which is a cancer supported discussion within the first 3 months, and then you've got the actual cancer care review within 6 to 12 months. I would suggest your practice has a process for recalling and looking at the list and getting the patients at the right time. That's what we have. That first 3 months goes really fast, because what happens is the patient gets seen, they get referred, then they get their appointment, they might go to MDT, and by the time you get their letter to say they have indeed got cancer, actually a number of weeks has already passed. So you'll then sort of go back foot. So we will do recalls very frequently. I think my manager does it sort of monthly or 3 weekly almost, and then gets patients booked into clinic for that. I sometimes find that our recall process is too good, and therefore I'm bringing the patient in when they haven't really got all the details themselves. So that first point of contact is that delicate time where you're calling them or bringing them in to talk, but actually if they've not actually got a treatment plan or they don't know what's happening, sometimes it can feel that you're not quite having a fruitful discussion, because they're desperately waiting to find out what will happen. And the first 3 months for the patient that has cancer is also quite a busy time. You know, they're going for scans, they're going for bloods, they might be going for outpatient appointments. So I have also found that just juggling appointments for those patients can be quite difficult. And especially if you bring in additional factors like mobility issues, where they need someone else to take them, or language issues, you know, it really then becomes quite a stressed time for that patient. So it's just trying to find a process where you're recalling them at the right time, you're both in a place where you at least have some information about their diagnosis and what their plan is going to be, and then signposting them to the Macmillan resources and websites, and then make sure they've got their nurse contact. It's interesting because I always say, and you've got your clinical nurse specialist card, or you've got your CNS card, they go, oh no, I haven't. And then I delve a bit more and they're like, oh, I've got a Macmillan nurse. So sometimes it's just using the right language for them, and that they won't realise that their Macmillan nurse and their CNS are actually one and the same thing. So just that first 3 months can be a bit tricky. Then again, as a practice, deciding who is the correct person to conduct the review and how you do it, and I think it will vary. It will vary according to your populace. So like I said, for us, a lot will be face-to-face, they might need an interpreter, and a lot according to what the patient actually wants. Sometimes patients can actually be quite overwhelmed at that time, and naturally they feel like there isn't a lot their GP can do in that first 3 months when they are trying. But actually, as a practice, decide what your process is and how you're going to do it to meet the needs of these patients. I've had so much positive feedback from people that say, oh, thanks doc, I just didn't think you'd quite be involved because you're a GP, and I know that the hospital's going to be doing a lot now. So actually it just opens that reconnection, and at a time when things are quite fraught for the patient, it just reminds them that you are there as their advocate, as we are as their GPs or their primary care clinicians. As I touched before, there is a balance. There is a balance of the relentless demand in general practice and offering a meaningful CCR, and sometimes you have to accept where you are and where the patient is and what the best you can do in the time that you've got. And I think, honestly, we are so time poor in primary care. I think every single contact that you come across, you could do so much more. I remember years ago when I was working with Cancer Research UK, and they said to me, I've got a wonderful project, Nigel. I said, yeah, it sounds really good, let's talk about it. And it was called A Teachable Moment. And what they decided, or they suggested, is that every single person that goes on a 2-week wait pathway actually, if they're negative cancer, bring them back into clinic and say, right, you were referred on this two-road pathway. That means that you obviously have risk factors for this cancer. What is it that you can change from a lifestyle point of view? Is it exercise? What is it? Diet? And that's such, teachable moment is so important. But again, you are facing an upward mountain as to what you can do with the fact that, I probably don't go home till 9 o'clock on a duty day. And even on a normal clinic day, trying to get all of those things done is not easy. But it's in your gift as clinicians, in your practices, and in your PCNs to decide what your process is going to be and what resource you're going to devote to the process. But all we would say is have good recalls, so you are touching patients at the right time in terms of their recalls, and using the ARRS template, because you will naturally go through all the sections and touch on those things. And sometimes it's actually really helpful, because when you tick on things like their social history, it's really serious when actually they care for their partner who's got dementia and yet they've got cancer, and now they're going to suddenly be going through lots of appointments and chemotherapy and surgery, and what's going to happen to their partner with dementia who relies on them for their care. So that would be sort of why we're sort of plugging the template as much as we can. Okay, so I've kind of said most of that. It's just that it is early in the journey in that first 3 months. So just pitch it right and know where you are. Okay, so I've got a couple of case studies to share with you. The first was a lady who was quite young who got diagnosed with breast cancer, and she registered with my practice when she got the breast cancer. So she was not a patient before then. She was living abroad. She then attended the urgent treatment centre over the weekend or on a Friday, something like that, with what she thought was an infection of her breast. She got seen by the urgent treatment centre clinician, who noted she had a severe fungating lesion with lymphadenopathy and with a swollen arm, and quite rightly sent her to the emergency department for a review of her significant findings. And very sadly, she was diagnosed with breast cancer with meds from ED. Now, that was a very difficult patient in the sense that she didn't have a general practitioner. She actually had lots of things going on personally, and she knew something was going on for it to sort of get to that level. And then she gets diagnosed with cancer from an ED presentation. And as you know, for years now, that's a big thing we've been trying to change. We are trying to plug as much of early diagnosis and early pickup and screening and everything else so that you don't have diagnoses of cancer from ED, which previously we did find from CRUK studies and various things which correlated with the fact that we had pockets of deprived population, pockets of populaces that then had vague symptoms that might not be presenting early or might not know that they should be seeing a doctor. And lots of work has been going on. Really excited Nisha's here. She's our Chief Cancer Champion, and for years we've had the project of training, developing cancer champions on all different communities that then talk about red flag symptoms in their communities, in their sort of close-knit communities. They're promoting things like, this is a red flag, if you have this, go and see your GP. It's really important. No one likes to talk about things like smears, but actually, you need to go and have your smear, you need to go and have your mammogram. So that work has been happening in the background, and I'm really happy to say that actually we are seeing the work that has been happening with those increased rates of screening and those increased rates of cancer diagnosis, moving from what used to be stage 3 and 4, late presentations, and getting a shift into stage 1 and 2. As you know, the government guidance is that we should be at 75% of cancers diagnosed in stage 1 and 2. And again, as part of the PCN DES that your practices would have been doing, we've been asking you to look at things like screening, targeted screening according to your practice. Which groups of patients do you find aren't engaging with screening? Is it your mental health population? Is it your learning disability population? Is it specific pockets that will have English as a second language? And we've asked practices to focus on those groups and try and get them through the screening process. So back to this lady. So she very sadly gets diagnosed with breast cancer in ED, and she then registers with the practice because she obviously needs to. I then start the journey and make contact with her, and at that time I find out a little bit more, which actually, if it wasn't for the process of a cancer care review within the first 3 months, I'm not sure she would have, managed to have got that appointment without her initiating it. And I don't think she was in a mental state or in an emotional state to initiate it, because at that time she was just concentrating on her 6-year-old daughter and supporting her husband, and actually had put her own health sort of on a back burner, which I'm sure lots of mums sitting here can probably empathise with. So she was really grateful that she got me ringing her saying, I'm Dr. Patel, I'd like to see you, can you come and see me, this is my intention. And she said that actually I'm really struggling because I need to have appointments for dressings, I need to do school pickup, school drop off, and all of those things. So we then could give her access to dressings. We gave her dressings so that she could have some at home. We gave her access. We put a note on her screen messages to say, please accommodate at all times, so that we could actually get her the dressing appointments when she needed. And I think that was really important to her in that time where she gets diagnosed with this cancer and gets told it's actually quite serious cancer that has spread, and her prognosis is not going to be good. And again, I think for me it was important that I had that opportunity to speak to her, and for her that opportunity to find out that we were aware of her, one of our thousands of patients, who did actually care, and what we could do to support her and help her through this process. Okay, so on the other end of the spectrum, another case study then. I had a sweet 80-year-old gentleman who was diagnosed with prostate cancer and was seen in clinic and was deemed sort of for medical management. And when I spoke to him, he said, well, I'm fine at the moment, but actually I live alone, so immediately that set up our sort of social process in our practice, looking at what his setup is like, whether he's got any family, whether he's got any friends, and we have a social prescriber, Sharon Bitted, so she was able to touch base with him, put him in touch with befriending groups, and just getting him some support in that time. And again, the process of having the recall and having him, in my registers as touch base points meant that actually he was on my radar and he could be supported as he needed to. And he's someone that will need support as he progresses in his disease, as do a lot of elderly people that live on their own. So I think it's important just to practice holistically and see where you are in terms of where each patient is and what they need from you as a practice. And you may find, so for us, for example, our social prescriber has done something called a Yellow Pages book. And that means that there's lots of resources in a Yellow Pages pamphlet, and we can actually give it to patients. And there's lots of things about voluntary services and various things, so that patients that are a bit lost don't know what things are available, and also clinicians don't always realise that there are these other avenues of support. And so we've created a pamphlet which actually has been a good success in our PCN. Okay, so I wasn't going to say much more, just that, if you have any questions, please let me know. I'm hoping that all of you have found the facilitation with Joyce really helpful. I think Mark's presentation about how we can really join up with secondary care and use the documentation that comes through, the end of treatment summaries, the holistic needs assessments, all of those actually to help us care for this patient group that has cancer as best we can under the finite resources that we have. Thank you.